Good evening, everyone. Thank you for joining Shield Connect. And I welcome all the participants who are joining for today's topic, Learn Simply at Tea Time. This program is organized by Nanded, Parbhani, Hingoli, and Pusad Obstetric Gynecology Society. So let me introduce everyone. So for the first topic, the first topic is placenta accreta syndrome, and this topic is will be covered by well-renowned doctor from Indore, Dr. Kavita Papat ma'am. And let me also introduce chairpersons of Hingoli and Parbhani Obstetric Gynecology Society. So Dr. Nandini Vaidya Bhagat ma'am. Ma'am is president of Hingoli Obstetric Gynecology Society from 22 to 24. Ma'am is consulting obstetrician and gynecologist in Bhagat Orthopedic Hospital and Maternity Nursing Home in Devda Nagar, Hingoli. Ma'am is also director of Bhagat Hospital, and ma'am is past vice president of Foxy Hingoli 2022. And special interest is women health in rural areas. So I welcome Dr. Nandini ma'am, and I also welcome Dr. Prasad Magar. Sir is working as a consultant in Parbhani, Maharashtra, and sir is president of Parbhani Obstetric Gynecology Society since 2020, and special interest is in BOH, medical disorders in pregnancy, infertility, high risk obstetrics. And I also welcome Dr. Kavita Bapat ma'am. Ma'am is Vice President of Foxy 2021-22, Organizing Secretary of AICOG 2022 Indore, and ma'am is Director of Bapat Hospital Indore. And ma'am is also Urogynecology Committee Chairperson EOFOG of 2022-2024. And I hand over the session to Dr. Kavita Bapat ma'am. Ma'am, I hand over the session to you. Thank you. Ma'am, please unmute.
Let me communicate with Nandini and Prasad, I think, so that we can discuss on it. You have introduced me. That's very good of you. Thank you so much. As I am contesting for the post of President Foxy, so I am supposed to communicate with each and everyone. The topic, I won't waste time. Nandini, should I start or anything to add anything?
No, ma'am, you can start. We are eager to listen you.
And so thank you so much. But I won't take much time, and I'm sharing my screen, and this is the subject. I think, am I visible, audible, everything?
Yeah, ma'am. Yeah.
Yes, ma'am.
Thank you so much. So it's a very, very good entity. Nowadays, we find it placenta accreta syndrome. So many cesarean sections, so many things, and this is going to be the another most important entity in future of one of the cause for the maternal mortality and morbidity. This is the placenta accreta syndrome, and too much. So all the glorious journey begins with a bright vision, as I always like to communicate with myself. And the introduction is, there is basically a spectrum of abnormal placental implantation from adherents, which are classified according to the depth of invasion into the uterus. It's because it's a program is Learn Simply. So we'll learn things very simply and very importantly. So placenta accreta syndrome. So these are the two major entities. This a small video where we can see after this where the placenta is and how it has been going inside. See all the lacunae and all that's been there, and it is invading almost into the myometrium. This is the case when we have done we removed the placenta, and this is the photograph of the placenta accreta. Then what is the adherent placenta syndrome? Number 1 is accreta, number 2 is increta, and then the third is a percreta. Accreta means total placenta accreta, involves all lobes. Partial placenta accreta involves only 2 lobes, and focal placenta accreta involves only single lobe. And these are the 3 variations which we can talk about. Now, what is the pathophysiology? It's a partial or a total absence of residue of bacillus, or there is a defective development of the fibrinoid, or the netabuc layer and result into the abnormally firm adherence. Then defect is a biological functions of the trophoblast, leading to excessive invasion into the myometrium. Then shift of the placental blood supply from the spiral artery, because it's basically to the radial artery to spiral artery, as found in a normal supply, is from the larger and deeper radial or the arcuate artery. So this is the basic difference. All the supply comes from the spiral artery instead of the radial and the arcuate arteries. And high velocity blood flow into uteroplacental circulation in the placental lacunae. So this is the problem. And hypervascularization pattern and placental blood flow is in a color Doppler. So this is the basic, the pathophysiology is. And these are the, we can again the differentiate between the what is normal placenta, complete placenta previa, and then this is a normal accreta, increta, and percreta. Increta, accreta up to the involvement, then increta, and then the percreta. So why we are worried about this placenta accreta syndrome? There are several risk factors nowadays for this. Number one is the placenta previa. Number two is the previous cesarean section. Multiparity is another risk factor. Advanced maternal age is another point. Uterine artery embolization, endometrial thermal ablation, vigorous multiple curettage is one of the reasons. And most important is the uterine pathologies. That is adenomyosis, biconvex uterus, submucous fibroid are the risk factors for this. And previous history of uterine surgeries like hysterectomy and myomectomy. So what actually happens? There are a few recently associated biochemical risk factors. We see the elevated first trimester PAPA-A, the number two, down regulation of specific microRNA, then elevated second trimester alpha-fetoproteins into the maternal serum and free beta HCG, then decreased TNF-related apoptosis, including trail receptors level, though we don't do all these levels, but these are the levels which say that this patient is going to end up into the placenta accreta syndrome. Myometrial fibers in the basal plate, this is the BPMYO, and maternal cells free beta HCG. So these are the recently associated biochemical result factors which we can detect the things early. So placenta accreta is iatrogenic in the 20th century disorder. Correct surgical technique while closing the uterine incision is also very, very important. Primary prevention of cesarean section and encouraging trial of labor is another important point. Treatment of postpartum endometritis, another important point, and avoiding vigorous curettage if whenever it is needed. So in a 21st century, these are the problems. In a placenta accreta, in a 20th century, it was a iatrogenic. So these are the 4 points. Now the advent of ultrasonography that has made a tremendous and amazing change into diagnosing the placenta accreta syndrome as early as possible, because they are more sensitive. They confirm the location of the placenta. They diagnose the placenta previa at the 20th week of gestation, and then the transabdominal scan. So the transvaginal scan has a better option. Now, grayscale has been a cornerstone in the diagnosis of placenta accreta due to its wide availability and a high accuracy. Sensitivity, 96 to 98%. Specificity, 77 to 78%. And PPV is 93%. And NPV is 98%. So sonographic image show the normal placenta. This is a retroplacental zone. There is nothing layer or something. It's a very normal. And white arrow that's showing the hypoechoic retroplacental space. Now the grayscale in a first trimester, the presence of anteriorly placed low-lying gestational sac on the TVS is one of the reasons we can think that in future that this patient can have a placenta accreta. Number two, between 2 to 6 to 8 weeks size of gestation. Number third, if there is a previous cesarean section delivery, considered a risk factor for the development of placenta accreta. So we can understand, we can diagnose the placenta accreta as early as possible with all these 3 things: anteriorly placed placenta, low-lying gestational sac at the 6 to 8 weeks, and a previous cesarean section. So low-lying placenta is one of the reasons again, and these are the points. So in a second trimester, there is a loss of retroplacental sonolucent zone. So this is also one of the points when we can diagnose as early as possible the placenta accreta syndrome. finding has high sensitivity of 100%. So see that to continue the pregnancy or not to continue the pregnancy, so many things we can discuss just early trimester. Low specificity of the 73%, and placenta is seen extending to the serosal surface of the bladder without any intervening myometrium. So you can understand how it is being gone into up to the level of bladder. Then the 2D color Doppler. It's a moth-eaten Swiss cheese appearance due to lacunae. This is the one of the reason, and obliteration of the clear space between the placenta and the uterine bud, and hypervascularity. Findings suggestive of placenta accreta are hypervascularity of a serosa bladder interface and diffuse of a focal lacunae flow, vascular lakes with turbulent flow, and that's a systolic velocity over 15 centimeter per centimeter square, and markedly dilated vessels over peripheral. Again, the color Doppler 2D, that's a 3D power Doppler has been shown to be superior than the color 2D in diagnosing the placenta accreta, placenta percreta from accreta, and there is a numerous coherent involving whole uterine serosa bladder junction, basal view, and you can see all red, and inseparable cotyledon and intravenous circulation is also point. So transvaginal transvaginal sonography, multiple tortuous hypoechoic structures within the placenta give the chances. Transverse abdominal 2D and Doppler USG confirm the hypoechoic pattern, and 3D Doppler sonography for diagnosis of the bladder invasion into the placenta percreta seen as a positive visualization. MRI has got a bigger role also. When to recommend a patient for MRI for the diagnostic of placenta percreta? When, number one, equivocal sonographic finding abnormal placentation. Though all of us know that the sonography is a gold standard, but some patients we have to get the MRI done. They are, this one is this abnormal placentation. Then evaluation of the posterior placenta in a patients with risk factors. If the patient is too much obese, then we need an MRI, and complementary role in a specifically denoting the extent of sonography diagnosis this placenta percreta. So imaging features of the normal presentation on MRI are, there is a homogeneous T2 intermediate sign, intensity of placenta, subtle, thin, regularly spaced placental septi, normal subseptal vascularity, triple layer sandwich appearance of myometrium. A simple thing is there. And a peer phase and a cardinal imaging finding for the diagnosis. All problem starts, dark intraplacental glands at T2, abnormal disorganized placental vascularity, and a focal interruption of the myometrial wall, and extension through the myometrium, occasional invasion of the adjacent structures. So MRI is useful in showing a parametrial extension which is not apparent on sonography. Now we will discuss 3 or 2 cases which are very, very important, and day to day we see this type of cases. 24-year female, gravida 3, para 1 plus 1, 37 weeks, 3 days, presented with leaking, preterm cesarean section 3 years back, and a spontaneous abortion. DNC done 1 year back, no NC visit, single 3rd trimester USG showing single live intrauterine fetus, appropriate gestational age, placenta posterior and low lying. Delivery of the fetus by repeated attempts to remove the placenta, but within few minutes it was realized it is adherent to the placenta and patient started bleeding profusely. This is a very normal and top of the cases which we see. Now the hysterectomy was done, but the patient went to irreversible shock and could not be revived back. Risk factors should always be borne in the mind. What will the take lesson learned from this? Number 1, the previous cesarean section should be investigated for the placenta accreta properly before doing the sonography. It was not done. High index of suspicion delivery should be planned in a tertiary center, which has not been done. Multidisciplinary approach is always needed, and the blood products should be ready, and forcible and unnecessary attempt to claw off the placenta should not be done, may provoke further torrential hemorrhage. So this is the risk factors and the point taken. So what is the triple P procedure? A novel uterine sparing procedure for placenta accreta syndrome. Steps. First P, Perioperative placental ultrasound, localization of the superior edge of the placenta. Second P, supposed to do the pelvic devascularization, preoperative placenta, intra-arterial balloon or a catheter or sometimes whatever is needed should be done. And third P is no attempt to remove the entire placenta, no pulling and pushing or anything of the placenta should be done. So first case, very simple, unbooked case, though the risk factors were there, hysterectomy being done, and they could not save the patient because of the irreversible shock and the right time not is it. Now this is the second case, 25-year, gravida 4, para 1, 2 with the history of full-term cesarean section, 4-year back, 2 spontaneous abortion, DNC done, came in active stage of labor at 37 weeks, 2 days, emergency cesarean section done. Intraoperatively, it was found a placenta accreta with a bladder involvement. Patient bled profusely. Subtotal hysterectomy was along with the ligation of blood vessel going into the bladder, but all in vain as patient vitally deteriorated. Patient developed DIC, anuria with ARF in a post-operative period because of the massive blood loss. How could she should be better managed? What should have been done? Previous cesarean section, most important, regular antenatal checkups. Sonography to diagnose placenta accreta as early as possible. Elective cesarean section should be the choice. For placenta accreta patients, bladder resection and reconstruction with the help of urosurgeons should be taken in the phase to save ourselves from the medico-legal issues. ICU care is very, very important for proper management and a complication of DIC, ARF, transfusion reaction, ARDS, and electrolyte imbalance. Timing of the delivery, RCOG says the elective cesarean section as asymptomatic. Women is not recommended before the 38 weeks of gestation of placenta previa, before 36 weeks or 7 weeks of gestation for the suspected placenta accreta. ACOG 20014, elective delivery by cesarean section at 34 to 35 weeks for the suspected placenta accreta. What makes hysterectomy different and difficult? That's another important point. Causes, unplanned hysterectomy. Emergency hysterectomy is an undiagnosed placenta previa. Inadvertent attempt to removal of the placenta. Delivery of baby by cutting through the placenta. So this is another point. Prevention, avoid cutting placenta. Transfundal approach is very, very good. Preventive surgical and radiological devascularization we can do early. Placement of the balloon occlusion catheter and placement of the pelvic pressure packing up like a phlebotomy device for balloon tamponade. Again, genitourinary tract injuries are very, very reported more in these cases, 6 to 29%. Urethral injuries up to 7%. And preoperative stenting of the ureters is preferred for better palpation and intraoperative, thus reducing the urethral trauma. Surgical technique, anterior surface of the uterus, preferably the lower second, should be inspected, followed by the lateral surface. Number 1, presence of any vascular channel noted should not be disturbed. Then uterine incision, classical transplantal cesarean section to avoid cutting through the placenta and delivery of the uterus, and closure of the intersection by a whip stitch. Then again, bilateral anterior division internal iliac ligation should be done and uterine artery ligation can be done. Cesarean hysterectomy considered as a gold standard treatment for the invasive accreta, although the high rates of severe maternal morbidity, 40 to 50%, mortality 7% are the problem. And what about the post-operative management? Very, very important, continuous monitoring of the vitals, high care specialty ward and a massive transfusion, monitoring of the recurrent intra-abdominal retroperitoneal bleeding, hypoinfusion and subsequent eye organ ischemia, they can lead to renal, cardiac, any other dysfunction, and even a Sheehan syndrome can occur. Early ambulation, compression devices can be used to prevent thromboembolic complications. Now the case 3. The saving the uterus is other priority. That's the third point is over there. G6P1, none alive. G8, 34 weeks. History of previous 1 section, 3 DNC. Color Doppler finding complete central placenta accreta with focal placenta increta. Elective cesarean section at 37 weeks. Bilateral uterine arteries ligation were ligated. Gentle removal of the placenta, not like a pulling and pushing with the placenta, possible leaving the adherent placenta in situ approach and the closure of the uterine incision. Saving of the uterus is our priority. Post-operatively, 2 units of blood transfused along with the methotrexate adjuvant treatment given. Patients managed successfully. Key points during the conservative management: gentle attempt of removal of the non-accreta portion of the placenta, thus the volume of the villus tissue left in situ. Preventive radiological and surgical devascularization, uterine hypogastric prevents the secondary hemorrhage and the placental resorption. Methotraction hastens the placental dissolution. All the risk of neutropenia, sepsis, secondary hemorrhage, and hysterectomy can be there. So can be given the methotrexate, but methotrexate we should not keep in mind that it is going to help us almost for the in situ placenta. It can cause the neutropenia, sepsis, secondary hemorrhage, and at the end of the day, hysterectomy can happen. Now, one-step conservative surgical approach: vascular disconnection of the newly formed fetal vessels, separation of the invaded uterus tissue from the invaded bladder tissue, and resection of all invaded myometrium with the placenta in one piece after a local vascularization. This is the second one. Not giving for the incision, but we want to remove all the myometrium together and we can save the uterus. And the surgical procedure for the hemostasis, myocardial reconstructions can be done with the 2 planes. We have to remove little more on more side of myometrium along with the vascularization and construct the myometrium in 2 planes. Bladder repair, if necessary, can be done. Then the arterial embolization, good or bad? UAE is an intervention technique in the cases of accreta, but not available in many setups. So therefore, uterine arterial ligation is life-saving. The role of interventional radiologist procedure, though looks promising, further research and prospective larger studies are yet to required. So we have a deadly D of accreta. Number 1, anything delayed, which will lead to anything. Delayed in a referral, delayed in a cesarean, delayed in decision of hysterectomy, number 1. Number 2 is a deficiency. What we are there? Deficiency in a time of availability, extensive additions, no time for the pre-op devascularization, deficiency of blood and blood products, and deficiency of ICU beds, and deficiency of the multidisciplinary team. So it's a 1D is delayed, 2nd D is deficiency. And the most important point, I'm just putting up a summary in like that. Before summary, I just want to add a few things. So what are the recommendations regarding the management of the X-Bear syndrome? Diagnosis of the placenta syndrome, strong recommendation, highly evidence that absence of ultrasound finding does not produce the diagnosis of the past, and it's unclear. So management is, again, we have discussed almost, and what is recommended and what is evident, what is highly evidence is very, very important. But the conservative management and expectant management should be considered carefully. It's a 2C, weak recommendation and low quality. Hysterectomy is basically the high quality evidence and the best. So the summary is like that. Placenta accreta syndrome spectrum is becoming increasingly common, associated with the significant morbidity and mortality. Knowledge of risk factors and antenatal imaging expertise can help and guide in diagnosis. Prevention for the delivery of postpartum care should involve a multidisciplinary team. And 4 components for the optional care is initiated simultaneously. Number 1, early antepartum consultation, guided by level of maternal care. Intrapartum and postpartum, this bleeding risk we should know. And ability and rapidly mobilize the blood products for the transfusion. And 4th important, monitoring and investigation. Must be investigated, all these things. This is initiated simultaneously and must be initiated simultaneously is very, very important. Again, the recommendations are challenging procedure. Cesarean hysterectomy can be challenging, should be performed by most experienced surgeons. When mass encounters at the time of delivery without prior suspicion of the diagnosis, we can lead to the medical, legal, and many issues of life. And there is a no extenuating circumstances mandating immediate delivery. Anesthesia staff should be alerted, and the case should be temporarily paused until the optimal surgical expertise is there. So very, very important. So thank you so much for the patient listening. And I am contesting for the post of President Foxy Please support me, and thank you so much for being with me in future. Thank you so much.
Thank you, madam. Good afternoon, everyone. Thank you, madam, for wonderful information. And everything you have told in each and every single detail, like triple P, double D, and which make it really unforgettable now. And I hope not only me, everyone who have joined this webinar, he will get or she will get benefit from this. And it's really honor and pleasure for me to chair your session, madam. Thank you so much for the organizing team and Dr. Anil Sakre sir for giving me this opportunity. And I don't think any questions will be there, but I just want to request everyone, if anyone has the questions, then they can ask madam. And, thank you so much, team, for giving me this opportunity. Thank you, madam.
And in chat box also anybody can write question. I don't think everybody, I know the moment we talk about the placenta accreta syndrome, half our mind goes in many more things. So it's only the right time diagnosis, right time referral, right time everything is very, very important. No delay, no nothing. So that's another important. But this is going to be important in future. See, always I say, I need 4 blessings from the God. In the next 100 lives, I will like to become obstetrician. But in the next life, I need 4 blessings from the God. Number 1 blessing which I'll need from the God is whatever the patient of recurrent pregnancy loss or any losses of there, I should be able to give them baby, number 1. Number 2, as being a gynec surgeon, how much lateral I should go, I should not touch the ureter. That's the second blessing I want from the God. Am I right? And the third and most important blessing which I want for the cases like a placenta accreta syndrome and everything like that, we should be able to save the mother, the child, and the most important, we should be able to save ourselves. If we are not able to save ourselves from the litigation, from the medical thing, from the issues, so many things are there. If you are not able to do it, it's a safe. And the most important things, we should be able to diagnose all the cancers or anything as early as possible so that we can give our women more and more good life than that. So I think all of you will agree that we need this type of 4 blessings in our future. Yes, somebody is raising hand. Krishna is raising. Oh, Dr. Kishore, namaskar.
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 I just want to have one remark that madam's presentation was quite informative. It's okay, but the slides were wonderful.
Thank you so much. Thank you so much. I am blessed. I am blessed. Virato, I am happy that you liked the presentation.
Wonderful, wonderful
slides.
presentation.
Thank you so much, sir. Thank you so much.
Yes. So over to Nishant. Nishant?
Okay, sir. Even Dr. Gayatri Rathod has written, it is a nice and informative.
Thanks. Thank you. Thank you, Gayatri. Nishat, continue. Nishat kahin chala gaya. Anil, you start.
Yeah.
Nice to see you, Manjusha. Everyone, I am happy to see those who have Krishna.
Really,
is there. Dr. Prasad is there.
Yes, yes, yes.
Yeah.
It was really a wonderful presentation, Kavita ma'am. It's really.
Thank you so much. Thank you so much. I am blessed. I am blessed. Yeah. We will cover all Maharashtra like this. Am I right?
Yes.
I'm supposed to. I'm supposed to. Thank you so much.
We never think that you are from Madhya Pradesh. You are from Maharashtra only.
I know, 100%, 100%.
Nishant?
You can start, no, another thing.
Yes.
You can start.
Kishore, Dr. Kishore is going to speak.
Someone Nishant is there. Nishant is there.
Yeah.
Nishant, please start next session.
Good afternoon, Atnur sir.
Namaskar.
So, so we are moving to our next session. It is the next session is the guest speaker for next session is Dr. Kishore Atnurkar. Probably everybody knows him. He's a renowned senior OBGYN from Nanded Society, and I would like to throw a light on his mastery to notice by the Kavita Bapat madam that he is working in a counseling, particularly counseling the family planning, and he has written many articles in the newspapers regarding male participation in family planning, and his
Amazing,
articles are
amazing.
so wonderful. He has written also one book. So he
It's a need of time, I think, the family planning. We have stopped talking about family planning, but it's a need of time. In the future,
Yeah.
when I'll make my manifesto, I'll definitely add these points over there. Because I have come from the family who has done so much work in a family planning. My father was Director of Medical and Services, Madhya Pradesh. So all the stabilization, very, very important. Good. You send me all your these things.
Okay.
The most important thing that I think he must be from all our Foxy members. He is the only man. He is the only man who has having documented more than 10,000 cesarean sections.
Oh my God.
Documentation. Yeah, that in last 23 years.
Amazing.
Yes, his work is very amazing. Written books giving minimal essential knowledge of commonly used contraceptive methods in
Amazing.
Marathi, Hindi, and English. Titles are Nirnay Tuja Mara Nirnay, and together we discuss. For hello.
Sorry for the technical error from my end.
Oh?
Dr. Kishore, you
Can
start
you hear
sharing
me?
screen,
So,
I think.
Dr.
Yes,
Kishore, we welcome you on our platform. You can start the session, sir.
Okay.
First stop sharing. Who is sharing this session now? Dr. Kishore?
Sahiti. Yeah.
Yeah, thank you.
Person is
Hi, Dr. Chandana.
for Dr. Atnurkar sir, Dr. Christopher, the secretary.
Okay.
He is as Dr. I think she's not there. I request again Dr. Nandini madam to accompany Dr. Krishna Pawar sir to chair the session.
Yes.
Sir, close this thing and just share your presentation.
Oh yes.
Please
काय
open the
करायचं?
presentation.
याला बंद करा सर सगळ्याला.
याला बंद कर ना.
हा सगळ्याला बंद करा. वरती क्रॉस आहे ना तिथून सगळ्याला बंद करा याला. Yeah, and now open your presentation. हे presentation आहे तुमचं?
हो नाही एक मिनिट.
Where is your presentation? त्याला ओपन करा. बस.
हो पण हे स्क्रीन
ब्लॅक जात नाहीये.
हे विंडो बंद करा ना.
हा ही बंद करा.
झालं आता आला.
नाही बंद नाही झालं अजून आता होईल. हा आता प्रेझेंटेशन उघडून घ्या सर तुमचं बस. येस यू आर थ्रू. त्याला खालतून मोठं करा बस. That's all. Thank you, sir. Good, excellent.
Okay, let us start with. In the beginning, I would like to thank everybody, particularly Anil Sakhre, Kavita Baput madam, all my chairperson Prasad Magar, everybody in the audience. I thank you very much for giving me this opportunity. When Anil Sakhre called me to present something, I thought that I should talk on understanding the importance of Robson classification. Well, Kavita madam talked about placenta, accreta, percreta, and all. I am trying to take you to a different world now. And I have worked on Robson classification for quite a long time now. And I thought that I should talk on understanding the importance of Robson classification. The reason behind choosing this topic is a latest letter from Rajya Kutumba Kalyan Karyalay Pune on 16th of December that फॉक्सीच्या साह्याने खासगी रुग्णालयामध्ये होणाऱ्या सिझेरियनचे वाढते प्रमाण कमी करण्याबाबत. And this is a long letter, and they have given tables and percentage about the cesarean section rates in year-wise in private sector. So the last line is that आपणास पुनश्च विनंती करण्यात सूचित करण्यात येते की शासन स्तरावर हा विषय संवेदनशील असल्याने शासन स्तरावर तसेच विविध स्वयंसेवी संस्थांद्वारे देखील याबाबत वारंवार विचारणा करण्यात येते आणि आक्षेपही घेतला जात असल्याने खाजगी रुग्णालयामध्ये अत्यावश्यक परिस्थितीमध्ये सिझेरियन प्रसूती करण्यासाठी मॉडिफाईड रॉब्सन क्रायटेरियाची खाजगी हॉस्पिटलमध्ये अंमलबजावणी करण्यात यावी त्यासाठी तशा सूचना आपल्या सर्व सदस्यांना आपल्या मार्फत दिल्या जाव्यात. दिस वॉज अ लेटर रिटन बाय गव्हर्नमेंट to all our FOXI members and societies. So some of us, they know Robson classification, and some of us, they really do not know anything about Robson classification. If the government has really asked us to do, so let us try to spread what is Robson classification. Well, friends, you will agree that it is always a battle between cesarean versus vaginal birth these days. Cesarean delivery generally has higher maternal risk for the current and subsequent pregnancies compared with the spontaneous vaginal birth. This is on page number, written on page number 48 in the latest edition of Williams Obstetrics. And FOXI also recommends the setting up of a cloud-based registry linked. So its website, which will collect anonymous data at the hospital level using the WHO recommended Robson's 10 group classification system as the first step in determining the range of cesarean section rates. Everybody is talking about the cesarean section rate has increased. Okay, but how to curb it? What is the first step? So why do we need to classify? Why at all we need to classify, and why at all we need to reduce the cesarean section rate? It is an attempt to find a solution to the complex problem of reducing the incidence of cesarean section. So that is why we need to classify it. It is the first step which will help to focus on a particular group, and it will in turn guide us to take further steps in decreasing the incidence of cesarean section. In 2015, WHO proposed the use of Robson classification, also known as the 10 group classification, as a global standard for assessing, monitoring, and comparing cesarean section rates, both within healthcare facilities and between them. The system classifies all women into one of the 10 categories that are mutually exclusive and, as I said, totally comprehensive. I mean, you perform cesarean section in any corner of the world, that cesarean section will fit into any group of these 10 groups of classification, Robson classification. The categories are very simple. They are based on 5 basic obstetric characteristics that are routinely collected in all maternities. For example, we note down the parity of the patient, number of fetuses, whether previous cesarean section is there or not, whether she is in the labor or not, what is the gestational age, and what is the fetal presentation. These are all the factors which we routinely register when the patient is admitted. So what is the Robson classification? So Michael Robson comes from National Maternity Hospital, Dublin. In 2001, has for the first time classified all the cesarean section. That's why it is Robson's classification. So Robson classification, for whatever indication a cesarean section is done, it can be accommodated in this classification, as I said earlier. It is not the classification of the indications. Please remember, it is denoting the status of the patient at the time of cesarean section. Everybody can do this. I mean, it is not necessary that all obstetricians should document the cases in Robson way. If you train your ward boy, if you train your sister, if you train your receptionist or any assistant doctor can really simply document the cesarean section in Robson way. I mean, whether the patient is primary or multi, full term or preterm, having previous cesarean section or no previous cesarean section, whether she is having breech, is she having multiple pregnancy. Secondly, whether she is in labor or the labor is induced, or if she is not in labor, I mean, the cesarean section is carried out before labor. I'll quickly go through the different groups. There are 10 groups. Group 1 is nullipara, singleton, cephalic presentation, more than 37 weeks, and in spontaneous labor, you label it as group 1 case. Secondly, group 2. In group 2, there are two subgroups, 2A and 2B. 2A means you have induced the labor, but it has failed induction, and therefore you are doing cesarean section. In 2B, is a cesarean section in nulliparous woman with cephalic presentation with 37 weeks pregnancy. If you are performing the cesarean section before labor, so document it as 2B. Then group 3 is a group of multiparous women of unscarred uterus who are in spontaneous labor, and group 4 is again of multiparous women, unscarred uterus. Group 4A is induced labor, and group 4B is cesarean section before labor. Then group 5 is a group of previous cesarean section. 5.1 if one previous cesarean section, 5.2 if two cesarean section earlier are done. Group C is of nulliparous breech. Group 7, multiparous breech, including all previous cesarean section. Group 8 is of multiple pregnancies. Group 9 is of abnormal lies, including previous cesarean section, but excluding breech. Group 10 belongs to all cases of preterm pregnancies, all singleton cephalic, less than 36 weeks pregnancies. So, what Robson classification is not for? Remember, Robson classification is not for controlling the rising trend of cesarean section. It is not analyzing the indications for cesarean section. Even it is not for deciding whether cesarean section was unnecessary or necessary. Why document in Robson way? Because it is the only classification of cesarean section available at present, which is accepted by WHO and recommended by FOXI and now desired by Government of Maharashtra. The Robson classification, WHO goes further and says that the Robson classification is for all women who delivered at a specific setting, for example, maternity or any region, and not only for the woman who delivered by cesarean section. सगळ्या फक्त cesarean section साठीच Robsonचं classification आहे असं समजू नका. It is a complete perinatal classification. Every woman who is admitted for delivery साठी पेशंट ऍडमिट झाल्याबरोबर तुम्ही रॉब्सनचं क्लासिफिकेशनचं ग्रुप तिला असाइन करू शकता. She can be immediately classified based on few basic characteristics which I already told you, which are usually routinely collected by obstetric care providers worldwide. Secondly, cesarean section rate, public versus private, is another burning topic these days. So it is well accepted that cesarean section rate in private hospital is much more than what WHO expects. Okay, but please remember that cesarean section rate in public hospitals, I thought that the cesarean section rate in public hospitals may be less than private, but it is not so. The figures in public hospitals are also more. They are also not meeting to the expectations of what WHO has recommended. So it is not that only private hospitals we are getting increased rate of cesarean sections. It is in public hospitals also. And I have published a paper recently that is readdressal of rise in cesarean section rates in public hospitals. Everybody is talking about the cesarean section incidence in private hospitals. I thought that let's go to public hospitals and decide. I collected 1 year data in 2021, and I could find that the cesarean section rate in public hospitals, in spite of having good infrastructure, in spite of having 2 or 3 different units, lot of residents, lot of teaching staff, rotations duties, holidays, etc., trained nursing staff, in spite of having all this positive infrastructure, the cesarean section rate in public hospitals is also more than what WHO has recommended. This is the table in which I show during 1 year of my study, in Government Medical College Hospital, Nanded, the cesarean section rate for that particular year was 38%. And in another women's hospital, it was 24.58%. So auditing the data of cesarean section by modified Robson criteria, as suggested by WHO, is a better way of classification. People all over the world have modified original Robson's classification, but let us go by what WHO says. We have studied and documented the data according to the Canadian modifications. I thank Dr. Arun Mahale, my teacher, my sir, is a very respected personality, who introduced me Robson for the first time few years back, and with his encouragement and inspiration, I am taking this work further. So thank you very much, Mahale sir, and thank you all for listening. Namaskar.
Thank you so much, sir, for giving crisp and detailed information. So, shall we go on the third topic? So, Saiti. So, now the third topic is the shoulder dystocia. And let me welcome Dr. Manjusha Tagal Palivar. Ma'am is the president of Pusad Obstetric Gynecology Society and vice president of Pusad Doctor Association. Ma'am is practicing obstetric and gynecology since 22 years and received Best Medical Officer Award by Government of Maharashtra in 1997. And let me introduce Dr. Sheetal Bandari. Ma'am is practicing obstetrician and gynecology in Pusat since last 20 years. Currently secretary of Pusat Obstetric Gynecology Society and director of Devashish Bhandari Hospital and Nursing Home Pusat. And now let me welcome Dr. Anil Sakhare sir, who made this webinar possible for today's session. Sir is Associate Professor and of Department of Obstetric and Gynecology in Dr. SC Government College of Nanded. Sir has worked as an Assistant Professor at GMC Nanded for 11 years under and postgraduate teacher and examiner faculty at various national and international conferences. Sir has published 19 scientific publications in various national and international journals, among the very few Indians who have contributed in William textbooks of obstetrics. And sir also reported one case report published it in International Reference Book of Operative Obstetrics by Cunningham. Served to African countries and operated hundreds of cases there through Rotary medical health camps, and experience of operating more than 4,000 NDVH cases and organizing secretary of AMOX 2017 Nanded. So I welcome Dr. Anil Sakhare sir for the third topic of this session. I welcome you, sir.
Before Anil speaks, I think Dr. Kishore spoke so well. Kanki for important topic hai, how to reduce the cesarean section rate. And all over India, we are just, all of us are striving hard to work on it. Manje, it's not only that the maternal mortality, but the cesarean section rate and why it has increased, why it has been the Robson criteria. Ultimately, it is working, but it's an analysis. Am I right, Dr. Kishore?
Yes, yes. It is the first step to know ये सगळ्यांनी जर केलं ना, ये सबने
तर
किया
आपल्याजवळ
तो
एक
अपने को
करेक्ट
पता चलेगा कि हम कहाँ है.
करेक्ट. म्हणजे त्यांनी एक सिम्पल एक डाटा कलेक्शन प्लस रजिस्ट्री सारखं विल कम टू नो की वाय अवर सिझेरियन सेक्शन रेट्स आर मोर.
No,
So
in which
everybody
group?
should use
In which
Robson
group?
criteria.
In which group the cases are being done more?
Very good.
We can know that, and
Correct.
so
Group
that
1A,
we
the
can
group 2, everything.
take measures to reduce. In some
Correct.
of the groups we cannot modify. I'm sorry, I am talking over you, but
No,
in
no, no.
some
No problem.
some groups we are we cannot modify. For example, group 9.
Yeah.
If it is
It is
transverse
because
line,
there is a single
but
abnormal
there
line.
are
So we
few
cannot.
groups, there are
Yeah.
few groups where we can modify, and let us first focus. व आपणच आधी आपण कुठे आहोत, आपण काय करत आहोत, कोणत्या
Yes.
ग्रुपमध्ये जास्त केसेस होत आहेत हे सगळं पाहिलं पाहिजे, आणि नंतर मग सिझेरियन सेक्शनचा इन्सिडन्स कमी करण्याच्या गोष्टी केल्या पाहिजेत, असं माझं
ऍक्च्युली इट्स अ बेसिकली सगळ्यांना रॉब्सन क्रायटेरिया मध्ये मी टाकलं असं लोकांना वाटतं की टू लर्न अँड रीड द रॉब्सन क्रायटेरिया अँड वी विल ऑटोमॅटिकली रिड्यूस द सिझेरियन सेक्शन. नो, इट्स नॉट लाईक दॅट. वी हॅव टू फिल अप द थिंग्स. वी शुड ऑडिट अवरसेल्फ. At the end of the day, we should audit ourselves की कुठे कुठे आपण मॉडिफायबल होऊ शकत होतो, कुठे आपण सिझेरियन सेक्शन करायलाच पाहिजे होतं आणि कुठे नाही करायला पाहिजे होतं. सो आय थिंक this chart should be available in each and every office. I think that and we should do our analysis of our own things. Thank you so much, Kishore sir. And over to you, Anil.
Yeah, at the outset, I must thank Kavita Bapat madam for arranging this webinar. Actually, his idea of taking such small webinars and important day-to-day obstetric topics, I really loved his idea that learn simply with tea time. Just we have a cup of tea and we should have some few take-home messages which we can practice in our day-to-day practice. I really like her concept that learn simply with tea time. With the permission of chairperson, I am starting my talk on shoulder dystocia. This is a smaller presentation, but hope it will revise this dreadful condition. So the objective of this talk is that we should know the definition, incidence, consequences, risk factors, and management of a shoulder dystocia. So there are various definitions explained in various textbooks. At least we have a 4 or 5 definitions for shoulder dystocia. The standard textbook, Williams Obstetrics, says that a head to body delivery time, if it is more than 60 seconds, if it is more than 1 minute, due to impaction of the shoulder against the symphysis pubis, it is called shoulder dystocia. The normal head to body delivery time is 24 seconds, 25 seconds. If it is more than 60 seconds, we can label it as a shoulder dystocia. The RCOG says that use of any of the obstetric maneuvers to release the shoulder after gentle downward traction has failed, that you can label it as a shoulder dystocia. So mean time of normal delivery from head to body delivery is 24 seconds. Head to shoulder delivery is 24 seconds, and mean time of delivery with dystocia is explained as more than 60 seconds. Few books explained it as than 79 seconds also. So as the definitions varies, the incidence also varies from region to region, from one observation to other observation, one study paper to other study paper, but it ranges from 0.6 to 1.5% depending on the definition, population, and weight of the baby. So whatever maybe the definition, whichever is the definition you are following, how to recognize it, I have a small videos that will self-explanatory to how to diagnose the shoulder dystocia when a woman is in labor. First alarming sign that when there is a prolonged first and second stage of labor, suspect shoulder dystocia. The second most important sign, and that is the only sign which may indicate that it is in a shoulder dystocia, that is called turtle sign. What is turtle sign? It is head bobbing, then retracting back in the birth canal. Just see this video, you can really get the idea what is meant by head bobbing, and head comes out and again goes inside the birth canal. That is turtle sign. The turtle bobs his head outside the shell and again it withdraws it inside the shell. That is called the turtle sign, And this is the most important clinical sign from which we can suspect or diagnose that it is a shoulder dystocia. Delivery of head with the arrest of shoulder delivery with usual delivery maneuvers. That is what we do to deliver the shoulder. We just give an episiotomy and just give a little bit of traction over the head. That is axial traction on the fetal head is the usual method to deliver the shoulder. And if a minimal downward traction does not affect delivery, if a minimal traction, that is very important word, does not delivering the shoulder, you should suspect that it is a shoulder dystocia. Why it is important? Why the diagnosis is important? Because it is an obstetric emergency. It increases maternal morbidity, it increases fetal morbidity and mortality. Even the fetal mortality is reported in shoulder dystocia is almost a 1%. So maternal impact is that postpartum hemorrhage, atony is the most common, soft tissue trauma, third and fourth degree tears are there. Symphyseal diastasis, though rare, but it is reported with shoulder dystocia. And in very rare cases, uterine rupture may be there if the case is of multipara or grand multipara. So fetal impacts are the fetal injuries. That is brachial plexus injuries in 4 to 16% of cases, fracture clavicle and humerus. And some cases may exhibit with the fetal hypoxia, neurological damage, and in 1% cases, death may be there. Brachial plexus injury is the most common complications of shoulder dystocia and most common cause for medical legal litigations in the United States of America in cases of shoulder dystocia. Due to downward traction on the neck, most important fetal effect is it stretches the brachial plexus. The baby's shoulder became impacted on the bone while the contraction continued to push the head forwards. So it will give a traction over brachial plexus. See the mechanism. So stretching and damaging it stretches the brachial plexus and damages the brachial plexus, which may lead to the Erb's palsy or punctus later on. So this is the most common cause for litigation in shoulder dystocia, and it is independent of operator experience. So incidence may vary, but it is independent. Whosoever is the obstetrician, it varies, though he is experienced or inexperienced. But the only good news is that the 80% cases of this brachial plexus injuries, particularly the Erb's paralysis, have complete resolution by 16 to 13 months after birth with a proper physiotherapy. So this is the only relieving factor in such cases. So what are the risk factors for shoulder dystocia? The most important risk factor, if there is a history of previous shoulder dystocia. If there is a history of previous shoulder dystocia, there is a risk up to 25%. Obesity, multiparity, if mother is having diabetes mellitus, short stature, and abnormal pelvic anatomy. The fetal factors which may have a risk factor for shoulder dystocia is fetal macrosomia, the large weight babies, particularly in cases of diabetes mellitus, post-death pregnancies, intrauterine fetal demesis, and instrumental delivery. So we have defined the shoulder dystocia. We know why, how to diagnose it, but can it be prevented? No. But there is a room for prediction and anticipation. We can't prevent the shoulder dystocia, but there is some chance that we can predict earlier and we can anticipate that there may be a shoulder dystocia. So how we can prevent of shoulder dystocia? It is 100% we can't prevent. Prevention of shoulder dystocia with cesarean section. When you think that there is a high risk factor to cause a shoulder dystocia, prior to labor should only be considered in unusual circumstances. Because if we do a cesarean section in every case of suspicious of shoulder dystocia or high risk of shoulder dystocia, again we have to go in Robson's classification, and again we audit those cases. It again increases the rate of cesarean section, and there is a chance that many of the cases may be delivered by vaginally. So only the cases, the elective cesarean section should be opted only in those cases where estimated fetal weight is more than 4250 grams, that is more than 4 kg in a diabetic mother. Expected fetal weight more than 5 kg in a non-diabetic mother. Or if there is a history prior shoulder dystocia with injury to the infant like brachial plexus, limb fracture or asphyxia. Only in such cases you may think for going to an elective cesarean section for prevention of shoulder dystocia in the pregnant. Also, good glycemic control in a diabetic mother, control of weight gain, and identifying risk factors can prevent shoulder dystocia during labor. But please, again, this is a very important statement that more than 50% of shoulder dystocia cases occur with an average weight of babies less than 4 kg. So even you are not suspecting that this case is in a high risk for shoulder dystocia, still there are chances that patient may land up into the shoulder dystocia. So what it should be, so always be ready, because shoulder dystocia is unpredictable and unpreventable. So what you should do when it is recognized that there is a shoulder dystocia? Three important things. Do not ask patient to push. Do not apply under pressure, and do not panic. So these three things you should do once you suspect that there is a shoulder dystocia. And remember helper. HELPERR. So management includes educate, involve the patient ahead of delivery. Involve the patient in delivery and just educate within few seconds that what is happening. Declutter the labor room. Call the senior persons, empty the bladder, stay calm, and go for helper. So these are the 5 important steps. You have to take action within seconds. Educate the patient, declutter the rooms, call the senior person, empty the bladder, be calm, and go for helper. So what is helper? Helper is H stands for call for help, E for evaluate for episiotomy, L for legs, that is McRoberts maneuver, P for suprapubic pressure, E for enter, that is internal rotational maneuvers, R for remove the posterior arm, and second R for roll the patient to the hands and knees. So you just remember this helper and you will go through it. Even you can combine one maneuver with other maneuver to deliver the shoulder. So what each dish helper steps, each step should be not to be tried for more than 60 seconds. It should be completed within 30 to 60 seconds. So all maneuvers should be completed in 3 to 5 minutes. There is no indication that any of these maneuvers is superior to any other. They represent a valuable tool to help clinicians to take effective steps to relieve impacted shoulder. Benefits of all these maneuvers are it increases the size of the bony pelvis, decreases the biacromial diameter, and change the relation of biacromial diameter with the bony pelvis. So H, call for help. So you should call a senior person who can help you. You can call other labor room staff. You can call your colleagues in such situation. And to go this, I recommend that every labor room or every labor room of institutions should have a shoulder dystocia drill, because these cases are not common. Even they happen, the drama ends in 5 minutes. So there will be no other person may miss what you have done to tackle with the shoulder dystocia. So every institution should conduct a shoulder dystocia drill which involves the teamwork and documentation of, and documentation is very important. Evaluate for episiotomy, not for all cases. It should be before the delivery, and it helps when applying the maneuvers. So give the generous episiotomy. This is the most important maneuver, that is called McRoberts maneuver. It is safe, simple, and effective, and it is used alone. The McRoberts used alone resolves the 40% cases of shoulder dystocia. So what is the Mac? It's very simple maneuver. Remove the bottom of the bed, placing the back flat, lift the bottom of the head, place the patient at the edge of the table, and flex the knees towards the patient head, towards the patient chest, that is abduct the thighs and flex the knees over the patient's patient's head. So what, again, see carefully what you have to do in man. You should have a two assistant for each leg, and you should give a clear cut macrobot's position to that patient. What it do, straighten the sacrum. Macrobot's maneuver, what it will do, it straightens the sacrum and moves the symphysis pubis towards the maternal head. It moves the symphysis pubis toward the maternal head. So it will again increase the symphyso diameter, and it help in disimpacting the shoulder. The second maneuver is the suprapubic pressure. So determine the position of the fetal back, and initially the pressure should be continuous, and later on it is like CPR, like rocking motion. So if Mac Roberts maneuver fails, you can use this suprapubic pressure along with Mac Roberts maneuver. So you should give a suprapubic pressure as we give like in CPR. First 30 seconds continuous pressure, and later the pressure should be like uh, CPR like pressure, so that it will disimpact the shoulder from the pubic symphysis. So now comes the E of a helper, that is internal maneuvers, Rubins and wood screws. These maneuvers, even I have not tried any of these maneuvers till now, but it looks easy, that rocking the fetus shoulder from side to side, that you insert your fingers inside the pelvis and rock the fetus shoulder from side to side. So what it will do, that it will disimpact the shoulder from the symphysis pubis and help in the delivery. It looks quite easy. Rubin's one maneuver looks easy, but Rubin's two and wood screw maneuvers are quite difficult to perform. This is Rubin's two maneuver, where the you should reach for the most immediate shoulder and push it forward, and which decreases the biacromial diameter and help in disimpacting the shoulder. So you have to insert your hand and reach to the most easy, that is posterior shoulder, which is most easily shoulder to reach, and push it forward, which decreases the biacromial diameter, and then deliver the shoulder. The wood screw maneuvers are that rotate the posterior shoulder 180-degree, and it can be carried out with anterior or posterior approach, but the posterior approach is said to be easiest one, and rotate the posterior shoulder in 180 degrees Celsius, and make it to come to the anterior side, and then deliver the shoulder. So this is a wood screw maneuver to be used in case of shoulder dystocia. If it fails, if the wood screw maneuver fails, you can try the reverse wood screw maneuver, that is posterior shoulder from behind. The R of helper is that remove, rather than trying removing the anterior shoulder, or rather than removing the anterior shoulder, remove the posterior arm. That is, this is called removing the posterior arm first. Pull the head, sweep in front of the baby, and then go for removing the anterior shoulder. This is the also one maneuver and can be used in case of shoulder dystocia. The last one is the roll the patient, and it is said that rolling the patient and making it to lie down on knees and palms, it increases the obstetric conjugate by 1.5 centimeter, and gravity also helps in movement itself. And say in this position, the other maneuvers can be applied, like wood screw maneuver or Rubin's maneuver you can use to disimpact the shoulder. So these are the helper. There are 7 maneuvers which we can use to disimpact the shoulder, and that can be carried out within 5 minutes. But what you will do if all maneuvers will fail? What is the last resort? So make a deliberate clavicular fracture, or make a Zavinel's maneuver, that is put a patient on tocolysis, replace the head inside the pelvic cavity, and do the cesarean section. All these procedures increases the morbidity, mortality both in mother and baby also. Or try for symphysotomy. Earlier the symphysotomy was the common operation to try it in difficult labor in African countries. But nowadays it is absolutely absolute for performing symphysotomy. Clitotomy or abdominal surgery for hysterectomy are the other options when all maneuvers will get failed. So take home message, shoulder dystocia is unpredictable and most occur in patients with no risk factor. 50% patients are there where there is no risk factor. Always be ready and calm while dealing with shoulder dystocia. Try mock drills in case of institutional delivery and train your young obstetricians. Know your helper. That is the key. All you should know the helper. All you should know all the maneuvers. Permanent fetal injury may be prevented by limiting non-axial traction on fetal head. That is the crux of all the don'ts during shoulder dystocia. Don't give a profound traction over fetal head. That will lead to brachial plexus injuries. Mock drill in labor rooms proved to be helpful in a need of action. Documentation is very important and debriefing after shoulder dystocia is an essential part of good patient care. So now we will move to practice. Thank you. Thank you very much.
Nice one. Nice, Anil. Good one.
Thank you. Thank you.
Good one.
Very nice information, sir.
Yeah, sir. Very excellent and truly exhaustive topic. Very, very, very well elaborated and needed to remind all the different aspects of management of shoulder dystocia, because this is a old topic, but we never look in different aspects. What should be done? What should be the management? What should be reminded? Everything was thorough and detailed. Thank you, sir. Thank you for such a elaborative, nice lecture.
Thank you, madam. Thank you.
Just एक point add करते कि whatever it is, the shoulder dystocia is basically obstetrician's nightmare. Am I right? Everyone will get agree. And हे नुसता point नहीं है. It can take you to court anytime. This is not only then की fetal damage झाला and maternal damage झाला म्हणून you cannot go to the court, but the court will ask you all the retrospective management also. The court will say what was the file entries, what was the sonography, what was the history taking while doing all these things, what were the measurements ultrasonography, what is the hematological profile. And it's not like that whatever the maneuvers you have done into the OT, I'm telling you, it's not end of it. It's not end of it, because that's not the will go into the court. Court will take everything, every issue of it. So we should be very, very careful in all the parts. Patient may end up into shoulder dystocia or not end up into shoulder dystocia. Our all the working should be similar and the regular the way should be. But excellent maneuvers and everything you have shown so nicely. Nice, Anil.
Thank you. Thank you. Thank you very much. Once again, I thanks Dr. Atnurkar sir, Dr. Kavita Bapat madam for taking their time to deliver the talk in this webinar. I really loved the idea. Kavita Bapat madam ची idea खूपच मला आवडली की learn simply with tea time. Just we have to spend half an hour and we should have some carry home messages to practice. So
thank you, sir.
We all. Thank you, Dr. Prasad, Dr. Nandini madam, Dr.
Kishore, everyone over there.
Dr. Manjusha ma'am, you are so cooperative in organizing this CME. We really
thank you very much
thank
for making us a part of this webinar. Thank you, Bapat madam. Thank you, Sakristan. Thank you all the team. Yeah.
आणि कविता मॅडम आमच्या सर्व चारही सोसायटी कडनं तुम्हाला खूप खूप शुभेच्छा.
Thank you so much. Heart of heart, I need it. Thank you so much.
Just to add, thank you, Bapat madam. It was nice to get interacted with you. Nice meeting you.
So sweet, so sweet.
प्रत्यक्ष भेटू एकदा. प्रत्यक्ष भेटू madam.
We will get आपल्याला पुष्कळ chances मिळणार आहे आता in future that we are going to. I think most of many of people AIC योजना कमी आले का लोक?
आमच्याकडनं कमी आले मॅडम, लगेचच
इतके अदरवाईज मला इतकी लोक भेटले ना आता ऑल द टाइम. सो मेनी पीपल आय मेट. सो लव टू मीट यू नंदिनी, डॉक्टर अँड साडी मध्ये पण भेटू आणि सगळ्या दूर भेटू. ओके अनिल, एव्हरीवन.
I also thank all the participants from Nanded, Parmani and Hingoli and Pusat society for making their time.
तुम्हाला पुसदला पण यायचंय.
नक्की नक्की मॅडम.
Good.
एक लिंक पोस्ट केलाय मी त्या चॅट बॉक्स मध्ये. दॅट इज गुड फॉर whom who want to join our announcement academic group.
Actually, that is very good. I will let you all the participants. Madam is running an Learn Simply Academy, and he posts a small amount of educational material every morning. I think
Not
he
every
posts at
morning,
5:30.
but twice a week, 2-minute reading or a 5-minute reading. आणि त्याच्याहून जास्ती
That's
आपल्याला
very good.
वाचवलं नाही